And now Dr. Diana Milowitz, who, in all honesty, has almost single-handedly developed this field, will give us her latest information.
So I want to thank the organizers for inviting me to talk, and thank Duke and John for all their nice comments. They haven't left me much to talk about here, actually, with their talks. And I'm going to disagree with some of the stuff you said on Lovis Dietz, respectively, just looking at the broader population of the patients. So really what we want to use genetics for is to identify who's at risk for these aneurysms so we can repair them before they progress to a dissection. But from the IRAD data, we know that there's a significant number of patients that present with dissections with minimal to little enlargement of the aorta. And we now know that genetic mutations will trigger some of those early dissections. And so not only will it tell us who's at risk, but also start to inform how to manage the aortic disease. And then finally, what happens after you repair the ascending aorta? Will they go on to have other vascular diseases? And so it can really tell us a lot about the personalized management for a patient. So what I'm really my work and what I'm going to focus on in these talks is the genes that we've identified today that really confer a very high risk for disease. So these are what we call Mendelian genes. By and large, they're autosomal dominantly inherited. So if somebody has a normal and a mutant gene, has a 50-50 chance of passing it on to their children. So it has this pattern of inheritance of being passed from one generation to the next, like Marfan syndrome. And you can have the syndromic end of the spectrum, like you have Marfan syndrome, where you can pick those people out of the population. But there are many more people that have an inherited risk that don't have those syndromic features. And as John mentioned, up to 20% of the patients with thoracic aortic disease will have a family history, suggesting that one of these very high-risk genes is being passed through the families. Interestingly, the genes that we're identifying for the syndromic and familial disease are also contributing to disease in the general population, but I don't have time to talk about that today. Been a lot said already about Marfan syndrome. We know how to manage this disease. We know we can watch that aortic root grow to 5.5 centimeters, and that they're at a very low risk of dissection before that. We know once we go in and prophylactically repair the aorta, there's a low risk for type B dissections, abdominal aneurysms, but not a risk for intracranial aneurysms or mesenteric aneurysms and so on. And I just want to mention briefly, since I was asked to talk about therapy, was the losartan trials. And the most recent one to be reported was the US trial, which is the largest trial worldwide. And they were really testing whether losartan works better than beta-adrenergic blocking agents and used atenolol for the study. And it was focused on children and young adults with Marfan syndrome. And the primary endpoint was to the change in the BSA adjusted aortic root size. And this is the end result of that study. It appeared that losartan worked as well as atenolol, but not better than atenolol. And there's some suggestion, if they had taken it out for one more year, that atenolol may have performed better than losartan. So right now, I think beta blockers are still the first line of therapy for patients with Marfan syndrome. And in addition, I worry there is some worldwide, in these trials, there's been a higher rate of events in the losartan arm than the atenolol arm or the atenolol, just depending on the study design. And the complications are always defined as dissection, surgical repair of the aneurysm, or death. And that was the case in the US trial. There was more events in the losartan arm than the atenolol. This did not reach significance, but there's a planned meta-analysis, so we'll put all this data together, and it'll be interesting to see if it reaches significance with all the trial data combined worldwide. Now I'm going to switch gears and talk about those Loeys-Dietz syndrome that are due to mutations in proteins that are involved in TGF-beta signaling. And right now we know that these mutations are all loss of function mutations. So you have all mutations in these genes involved in signaling. The mutations cause one gene not to make a protein or a dysfunctional protein, so you're decreasing TGF-beta signaling. But uniformly, when we look at the end-stage aorta, there's evidence of excessive TGF-beta signaling. So there's still this paradox in the field that we don't understand. These are the list of genes that have been identified, and now they're all being grouped as Loeys-Dietz, and the recommended management is this very aggressive repair of the aortic root that was primarily defined by the group at Hopkins using mostly a pediatric population. And as Duke said, the more severe end of the spectrum gets described initially. These patients, no matter what the underlying gene, may have some marfanoid skeletal features. They may have, they all have autosomal dominant inheritance. They all have the aortic root aneurysms. And they go on to find aneurysms and dissections of other arteries and have the arterial tortuosity. Although if you look at the full spectrum of the disease, the tortuosity in many patients are similar to what we see in Marfan patients. And so it's not really clear that the tortuosity is more than Marfan's or the genes causing familial disease. And the syndromic features specific for Loeys-Dietz, Duke already went through, so I won't go through this. Now the big question is, are we managing these patients correctly with this very aggressive management? And I just want to remind you that this management is based on these severely affected young patients that, that have been initially described at Hopkins. But at the same time, we know that there's many patients that look like classic Marfan patients. And actually, the TGF-beta2 mutations were initially described as being Marfan syndrome 2. And at the other end of the spectrum, we have people that look completely normal, don't have Marfan features, don't have any of these features of Loeys-Dietz, and still have mutations in these same genes. And we have patients with TGF-beta2 mutations that are in their 80s and haven't had any surgical repair. And so we have this wide spectrum of disease, but in reality, the vast majority of patients with mutations will fall out here because these patients will go on to reproduce and have children, whereas this end of the spectrum will not, and they have this very severe aggressive disease that Duke talked about. And I just want to point out to you that our data in Houston as to when we should time these surgery is different based on whether they have a TGF-beta1 or TGF-beta2 mutation. Here's the size of the aortic root in patients with TGF-beta2, and it's just slightly, at the time of dissection, it's slightly over 4 centimeters. So I would agree with that very aggressive management for TGF-beta2. But here's the size of the aorta in patients with TGF-beta1, and half of them had aneurysms that were 6 centimeters in size. So I'm not entirely convinced, and we've published this data, and now we've formed an international consortium to really get data from patients worldwide and the full spectrum of the data. But I would argue that we're being overly aggressive in managing TGF-beta1, and that may be the same for some of these other genes. So what we really want to emphasize that we want to drill down and have it based on the underlying gene and define the outcomes with the underlying gene to make sure that we're managing these patients correctly. Now I'm going to turn and talk about familial disease where they have no syndromic features. And as John already mentioned, the majority of these families have the autosomal dominant inheritance where it gets passed from one generation to the next. There can be decreased penetrance, and that's when somebody gets the mutant gene but doesn't have the disease, can pass it on to their children and see their children die of dissections. And that's really illustrated in this woman here whose father and brother had aortic disease. her children both had dissections, but she's in her 80s and still has a completely normal aorta and no dissections. We see a large amount of clinical heterogeneity in the families with familial inheritance of this disease, and that sort of suggested that there were a lot of underlying genes causing this disorder, and that is the case. Here's the genes identified to date. In fact, we just had 2 more genes come out in the last couple months, and I forgot to update this slide. We have 2 more genes in review right now. So this is rapidly evolving, and it's really the standard for adult onset cardiovascular diseases that there are a lot of genes that can be altered as you go from family to family that still cause the same presentation, the same cardiovascular condition to be inherited in the family. So these are the genes. You can see right away that we have all these genes that cause syndromic disease, that we can pick up mutations in these same genes in a small percent of our people with no syndromic features. Up here are truly genes that don't cause a Marfan or Loeys-Dietz phenotype at all. And the major gene is ACTA2, which includes the major protein in the smooth muscle cells that line the arteries in the aorta, and that's responsible from anywhere to 12 to 20% of the disease. You can see, despite identifying 9 genes, we can only explain the disease in about a quarter of our family. And I'm going to spend the last few minutes talking about the data on our first 277 patients with ACTA2 when we assessed the aortic presentation and outcomes in these patients. And this is a patient with an ACTA2 mutation, looks completely normal. You'd never suspect she was at risk for dissection, which she had shortly after giving birth to her daughter. And ACTA2 mutations cause thoracic aortic disease, but instead of causing aneurysms and dissections of our other arteries, they actually cause early onset occlusive disease, including coronary artery disease and early onset stroke. So the story is very different with this particular disease in comparison with Loeys-Dietz, and you have to screen them for coronary artery disease and cerebral vascular occlusive disease. So these patients do form fusiform aneurysms of the ascending, involving both the root and the ascending aorta. Here's another one with effacement of the sinotubular ejection and extension up into the arch. And so we're recommending, if you go into repair, that you repair from the root up into the arch in these patients because they have such diffuse enlargement of the aorta. If we look at the size of the aorta, the maximum diameter at the time of dissection, you can see that there's a good quarter of the patients that have dissections under 5 centimeters, so we're recommending repair at 4.5 centimeters. Interesting, these dissections at very minimal enlargement were mostly in women with pregnancy. And this is a comparison of how these patients present with ACTA2 mutations versus TGF-B2 and FBN1 mutations. So for a patient with Marfan syndrome, most of them present with the skeletal or ocular features, and then the aortic disease is picked up. So only a small percent actually present with aortic disease, whereas the vast majority of patients with ACTA2 are presenting with aortic disease, and most of them are presenting with aortic dissections. Almost 90% of them, the first time they're coming to medical attention is with an acute dissection, where that's only 40% in patients with FBN1 mutations. It's mostly type A dissections, but type B dissections are more common in ACTA2 patients than they are in either Marfan or TGF-B2 mutations. And interesting, the type B dissections are occurring on average in younger people in the family than the type A dissection, significantly younger. So if you see somebody with a type B dissection at a young age without syndromic features, think ACTA2 mutations. And right now for Houston, that's 100% accurate. We are picking up a lot of, down to 14 years of age, very young type B dissections. And very few are presenting for ascending aortic aneurysm repair, prophylactic repair, only 17% versus 80% of the Marfan cohort. So that's just a brief illustration of how the aortic disease is presenting in patients with ACTA2 and how they need to be, we need to be much more aggressive about getting a family history and doing genetic testing so we can get ahead of this disease and make sure that we pick it up prior to dissection in these families. So just to talk about the genetic management, we're really, as Dr. Cameron already talked about, we're really, and Dr. Eleftheriades, we're pushing a gene-specific management if you know the underlying gene. It'll help identify who's in the family is at risk and who needs to be followed for an aortic aneurysm, but it also tells you the timing of the surgical repair and risk for other vascular diseases. When to do genetic testing, anytime you see these syndromic features in the patients, they should be tested. And like I said, you may have a person that looks like classic Marfan syndrome that shows up with a mutation in TGF-B or 1, 2, SMAD3, or TGF-B2. We're also recommending anybody with a family history of the disease and has the disease themselves undergo testing. Anybody with a young age of onset of aortic disease, it's more likely to be genetically triggered. And then any pregnancy-associated dissection, which also falls into that young age of onset. If you find the gene, you can go to very gene-specific management and then screen the family for other potentially affected. If you have a family history of disease and there's been no gene identified yet, then you need to screen all the members at risk for aortic disease, and the timing of surgery and risk for other vascular disease has to be based on the family history. And finally, if there's no family history and no syndromic features, then we're still recommending screening the first-degree relatives because it's not uncommon that they may have been told grandpa died of a heart attack when it in truth was actually an aortic dissection. So you will pick up asymptomatic aneurysms. So, so thank you very much, and I'd just like to thank all the patients and families in our study and our source of funding. So thank you.
Thank you.